give all the time about Hep C prevention, and I've interspersed it a bit with some work that we've done through BDP. So that's probably lengthened my talk, so I'll try and do that as well. So this is one of those numbers that it's fuzzy because it's uncertain. So this is the number of people with hepatitis C or infected with hepatitis C in the UK. There's about 190,000. 85% of people with hepatitis C acquired it through injected drug use. But actually, when you take out people who've acquired it abroad, 90% of infections in the UK were acquired through injectable drug use. So they're either among current injectors or people who have ceased injecting, which is why Paul suggests that, saying Hep C is the next critical epidemic for people, for policymakers to get interested in, well, it's a bit of a more difficult ask. But it does mean that preventing hepatitis C among injectors is critical to preventing liver disease associated with hepatitis C in the population. Now this is one of those numbers. So that slide is a bit old. We recently, with BDP and with the government, we re-estimated how many people were injecting drug users in Bristol, and it came to around just under 1%, or 2,770. And this was twice as much as the official Home Office estimate, or what we call in epidemiological speaking is in conflict, or inconsistent with. Otherwise, we think the other number was wrong. And because actually what we did, we fixed the method, but then when we tried to apply that nationally, it sort of fell apart. So actually, nationally, when we apply their methods, we get a prevalence of 1.6 billion heroin users, opiate users in the UK. Now, there's no way there is that many, it's just the method is a bit problematic. So we've redone that, and now we think there's about 276,000. So all I'm going to say is that the method that we tried, that we used with BDP, that we did in Bristol, we've then revised that nationally, and we'll feed that back into those estimates of how many people have got hepatitis C as well. So that's one example of BDP work. So I'm going to talk, and I see Viv's at the back, I hope I'm not completely nicked all of his slides. She's going to do that. When I talk about prevention of hepatitis C, we should talk about primary prevention first, and that's opioid substitution treatment and needle and syringe programs. And there was, until very recently, no quantifiable evidence that methadone, buprenorphine, and needle exchange actually reduced transmission of hepatitis C. So we pulled some data in the UK, including 2 or 3 studies from Bristol, and showed that opioid substitution treatment reduced hepatitis C by more than a half, as did high coverage needle exchange. And the combination of those two reduced transmission by about 80%. So this was the first quantified evidence, and this led then to a global systematic review, which I'll show you a bit about. But by the by, it also then inspired us at BDP and with Matthew Barber and the trials unit here to think, well, given that opioid substitution treatment is such a good thing, why don't we do a trial of what we called script in a day, which is where we had caseworkers working at BDP needle exchange saying, if you're not on a script and you want a script, we can take you around to Matthew's surgery in a couple of hours, you'll be on script. And we thought that sounded quite sharp. What a great idea. And then this is summarised outcome, which was who's on a script after 3 months, those randomised and not randomised. And it doesn't say the statistician, I want to say that we couldn't try harder to get a null finding. There was no difference. So sadly, insufficient support, as we say, for going to a fuller trial. But at least we did a trial, and I hope BDP enjoyed it, would like to do more trials later, rather than just epidemiological studies. So, moving to the global review, and this is one of the things that's just going to come out, it's not published yet. So, and again, data from BDP contributes to this global review for opioid substitution treatment will come out for Cochrane Drug and Alcohol Journal, I think, in a couple of months, and supports our early evidence that people on opioid substitution treatment have at least half the risk of acquiring hepatitis C than those who are not on opioid substitution treatment. The evidence for needle syringe programs is more heterogeneous and weaker, and partly there's a few studies in America where they find null findings. So when you synthesize globally, you find weak evidence. But if we just look at Europe, well, we're still in Europe, that the evidence seems still, again, quite strong, that at least half the risk of people with high coverage needle exchange at least reduces transmission by about half. And again, the combination is even stronger of opioid substitution treatment and high coverage needle exchange. Now this again is unpublished, which is we've recently tried to update nice reviews of the effectiveness of needle exchange programs, and Bristol is one of our sites with Walsall and Dundee. And what this slide shows, this is called a sort of incremental cost effectiveness ratio frontier, so forget about that. Ooh, great, thank you. That means I can move away from the mic. No, you can't. So the bottom line is that the cost it's incredibly cost effective. So it's about the mean, and it might change a bit, was about £700 per quality. So if you think about what NICE says, they want to promote things that are under £20,000 per quality. So high coverage needle exchange, the average was £700. Under some scenarios, it was even cost saving. So not just cost effective, cost saving, because of the impact it could have on removing people with hepatitis C. But again, a lot of uncertainty, and this might change a little, but I think it's looking good news for high coverage needle exchange. So the obvious thing is, well, in our first point, why don't we just increase opioid substitution treatment and increase high coverage needle exchange, and we will sort out hepatitis C transmission. So I won't bore you with that. So this is one of several models that we now, so now we're in the scenario world, or modelling world, where we set up different experiments within a computer and say, well, what would happen if? So what this shows is that this is sort of slightly similar to actually the UK and similar to Bristol, where the chronic hepatitis C prevalence is about 40% among people who inject drugs. And we started off in our baseline with about 50% coverage of opioid substitution treatment or needle exchange. And then what happens is if we take away those interventions, if we take away methadone, if we take away high coverage needle exchange, what happens is that prevalence of hepatitis C will jump right back to what it was like in the 1980s, early 80s, of nearly 70% chronic hepatitis C, and that's chronic hepatitis C, so antibody positive would be over 80–85%. So it averts infections. But if we increase from 50% to 60%, we find very modest impacts on transmission, on prevalence. It takes a long time. And only if we sort of really ramp it up to a coverage of 80%, which might not be achievable for 10 years or 20 years, so 80% coverage for 20 years, will we start to see some substantial reduction in the prevalence of hepatitis C. So we've got these interventions which are successful, they're averting infections, but they're not the only answer to really having a large effect on hepatitis C. So then we started thinking about, well, okay, HIV treatment is now being promoted and is accepted as a treatment, as prevention, as well as reducing morbidity among patients on treatment, as well as reducing viral load so that you can reduce ongoing transmission. So the question again is, well, can we use hepatitis C treatment in a similar way as for prevention? So again, I'll send these out to you later if you want to look at the models and the papers. But again, so we have a scenario where we simulate a population of injecting drug users with a specific prevalence, whether it's 20%, 40%, or 60% of chronic infection. Then we introduce hepatitis C treatment, and then we see and project what would happen at different rates of hepatitis C treatment on the prevalence in the population. So, and then also, because we want to get a bit economic, we tack onto that impact a progression model which tracks people from mild disease to moderate disease to whether they're going to get liver cancer, whether they're going to die from hepatitis C or other causes. And we can then put on costs so that we can then compare how cost effective it is to treat people who inject drugs versus people who have ceased injecting or non-injecting. And the reason why we do this is this is a dynamic process. So if you treat someone with hepatitis C as an injecting drug user, they're at risk of being reinfected. And all the talk 10 years ago, 5 years ago, which I think we've changed, BDP and others have changed, is well, it's not worth treating people because they get reinfected. Well, actually, some people might get reinfected, but also you're preventing other infections. So the critical dynamic is, are you averting more infections than reinfections occur? So that also we can show in our models. So the first model, or evidence that came some while ago, 2011, and this shows for 3 different populations with chronic hepatitis C is 20%, 40%, 60%, and various scaling up of hepatitis C treatment, basically finding that relatively modest rates of hepatitis C treatment can achieve quite substantial reductions in hepatitis C. So we then moved to a model which combined opioid substitution treatment and needle and syringe programs and scaling up hep C treatment. So we sort of created this heat map or topology where you've got hepatitis C treatments increasing up here on the horizontal. That's the vertical. On the horizontal, you've got increasing the coverage of opioid substitution and high coverage needle exchange. And up towards here, you've got this, towards elimination, 80–90% reduction in hepatitis C, and down here very little. And the bottom line of those models was that if we wanted to, say, have a substantial reduction in hepatitis C, say, reduce it by 40% in 10 years, we had to have hep C treatment. We couldn't rely solely on scaling up needle exchange or opioid substitution treatment. But critically also, as you scale up opioid substitution treatment and needle and syringe programs, you need fewer hepatitis C treatments to achieve your impact. So there's a positive synergy going on between these interventions. And this is what it shows here. So this is the annual treatment rates per 1,000 injectors you need to halve chronic prevalence in 10 years, with when you've got 20%, 40%, or 60%. And this is how it shows that as you increase the coverage of opioid substitution treatment and high coverage needle exchange, the numbers you need fall substantially. And that's very important when you've got treatments which now are 20, 30,000, maybe 70,000 pounds. But even when they drop, they're still going to be a couple of grand. They're still going to be quite expensive. So, showing that there could be impact, what we were interested in is also showing, well, what about, is it more cost effective to treat people who inject drugs early? What about thinking about prioritization? If you were a physician, clinician, or nurse, with a patient in front of you, would you prioritize early treatment to people who inject drugs, or say, no, actually we should delay treatment until they've got moderate or later disease? And the clinical recommendations have changed, to be honest, on not very much evidence, but what they've changed from a position in 2014 of saying we should provide hepatitis C treatment based on severity of disease, because the people with more severe disease will benefit quicker. There'll be more quality gain, as you like, quality suggested likely gain. And that's now changed slightly as a result of some of our work and others to saying, well, actually, treatment should also be prioritised to people who've got a risk of transmitting to other people. So people who inject drugs, men who have sex with men who are also co-infected with HIV as well, where that's where all the incident infections going on in the UK among people who inject drugs and MSF. So now they're suggesting, well, we should prioritise those treatment groups as well. But again, as I said, not on any evidence. So what we wanted to do is we set up another scenario where in our three populations, whether you had 20% chronic hepatitis C or 40% or 60%, we said the baseline is to treat people with cirrhosis. And then to consider, well, who would you treat next? Who would you treat early? Would you treat people who inject drugs or people who've got a risk of reinfection but also have got a prevention benefit? Or would you delay treatment in those populations and then treat people with moderate disease who have not got a risk of reinfection? And I forgot to say that the new direct-acting antivirals, as well as being expensive, are incredibly effective. You know, 8 to 10 weeks, 95% cure rate, £70,000, maybe 30. Portugal, a bit cheaper, France, a bit cheaper. Anyway, we don't know what the governments are actually paying for the drugs. At the moment, they're expensive. They will fall soon. In populations where chronic prevalence is about 20%, after treating people with cirrhosis, with severe liver disease, you would treat injecting drug users. People who inject drugs with either moderate or mild disease over any other population group. You would prioritise early treatment to people who inject drugs because of the benefits of preventing ongoing infections. Even in populations where chronic prevalence is slightly higher, 40%, which is like Bristol, like England as a whole, I mean, there are populations in the UK with 20% chronic prevalence among injecting drug users. But even when it's 40%, under this economic model, you would still prioritise people who inject drugs with moderate or mild disease for early treatment. And it's only when you get to populations with very high rates of hepatitis C, very high incidence, very high likelihood of reinfection, would you delay treatment among people who inject drugs and then prioritise other population groups with moderate disease. And when I say delay treatment, that doesn't mean not treat. That means you treat when their liver gets a little bit more scarred, and then you treat. But on this model, actually in these populations, we would be prioritising early treatment to people who inject drugs. And these rankings hold irrespective of the cost of the drug. So although at the moment the drugs are expensive, even when the drugs become cheaper, which they will inevitably become cheaper, maybe in a couple of years, maybe in 5 years, definitely in 10 years, those rankings hold. So we would prioritise early treatment to people who inject drugs because of the prevention benefit on the model. And this is why, because when you treat someone in a population, say, with 20% chronic prevalence, and that could be, there are places in North Wales, places in northeast of Scotland like that. For every person you treat successfully, you prevent over 2 infections, further infections. And even in a population with chronic prevalence of 40%, for every person you treat, you're also preventing another infection. So that's where the benefit comes. Much more from the individual, much more from the prevention of liver disease among the person you treat. We're getting some herd immunity going on. We're getting some reduction in transmission. I wish I hadn't said herd immunity there, it's actually not true. Right, so the other thing that we did is we wanted to ask is, well, are current treatment rates that are going on in Bristol and elsewhere sufficient for us to see a prevention benefit in the population, for us to see a reduction in hepatitis C prevalence among people who inject drugs? And so this shows for Bristol, East London, Manchester, Nottingham, Plymouth, Dundee, North Wales. This is what the prevalence is now in blue. This is what it will be if we continue with current treatment rates. In other words, there'll be no difference. The current treatment rates are not sufficient. They're probably doing it, they're probably effective, but we won't be able to observe it we won't be able to see it. It's only if we scale up hepatitis C treatment we'll be able to see a reduction in prevalence. And that's true in Bristol, as it is, and in England as it is across Europe. So inspired by that study, again, which is work that we did with BDP and University of Bristol Trust, when we look across Amsterdam, Belgium, Czech Republic, Denmark, Finland, France, Hamburg, Norway, Scotland, Slovenia, Sweden, most of these countries are not treating at a high enough rate to when they switch these new exciting drugs, to see a difference. I mean, even places like Czech Republic and Slovenia, where they've got lower prevalence, they're more likely to see an effect. Also, the other issue is the uncertainty. So we're either not going to see effect because of the uncertainty, or we're not going to see effect because actually you're not treating enough. So it's only with this massive scale up will we see these changes. So I wanted to conclude and stop. So I wanted to also end on not a subtlety, but on an important distinction. What I showed you for opioid substitution treatment and needle and syringe programs in terms of the synthesized effects of their synthesized effects on hepatitis C transmission, that comes from real studies. So studies which have followed people up and shown that hep C transmission is lower in people with needle exchange, people with opioid substitution treatment. We've also, and they are highly cost effective, those therapies. And we'll be publishing soon that in some scenarios they're in cost saving. Actually, opioid substitution treatment, as Paul knows, when you add in crime, there is no lower limit of how much methadone you would want to provide to the population. You would want to put as many people as one ever on methadone. I mean, obviously they have to be opioid dependent, but what you would put them on methadone. It's massively cost effective. We've got really good evidence that these new drugs are fantastic. They will reduce, they will cure. People who are cured have a much less likelihood of getting liver cancer. So the treatment priority is to reduce liver disease in the population. One of the things is to ramp up treatment for people, identify people who've got moderate and severe disease and make sure that they're treated as quickly as possible. There's no empirical evidence as yet that ramping up hepatitis C treatment leads to prevention benefit. We've shown in our models that it does, but what we need now is experimental evidence. So what we need now is support in Bristol and BDP and elsewhere to think, right, what we've got to do now in the next 3 to 5 years before these drugs become cheaper is to build the evidence base and show that treatment is prevention when it